Okay, so question number 81. A 50-year-old male is found unconscious in his car. There were no witnesses to the event. When gathering medical history information for this patient, the EMTB should what? Yeah, so of these possible answer choices, the only one that really makes sense to do is C. When you want to get a medical history, you don't wait for family members. Any answer choice that involves waiting, I think I've mentioned this before, is pretty much going to be wrong. If the answer choice is just to wait for something to happen, that's never going to be the correct answer. There's always something you can do instead of literally just sit around and do nothing. C is the best one that you can do to actually be active. You wouldn't necessarily want to ask law enforcement officials if they're familiar with the patient. I would like to think that most police officers won't be familiar with most patients you have. Certainly if I were found unconscious in my car and you asked the police, like, they'd have no idea because I have never been arrested. So that's not really going to help you out for most patients. So the answer is C. Number 82. The most appropriate treatment for a patient with severe abdominal pain and signs of shock includes what? Severe abdominal pain and signs of shock. Okay, are you saying that? Are you saying A because I've told you all that oxygen answers are usually correct answers? The answer would be C, yeah. Because in this case, we don't know really anything about the airway breathing situation, but they're pointing towards somebody who's having a major life-threatening problem. We don't really know what. Severe abdominal pain and signs of shock, my best guess would be some sort of GI bleed or maybe even some sort of abdominal aorta type thing. We don't really know. We just know abdominal and signs of shock, so probably lost blood. Based on that, you'd want to transport him right away because all of a sudden this is now a circulation issue. It's a bleeding issue. The others just don't really make sense. You wouldn't give a nasal cannula. If you did anything, it'd probably be via a non-rebreather if you were to give oxygen, which wouldn't hurt. I mean, it's just not the main thing at this point. Number 83, this is straight up facts. The three major parts of the brain. The cerebrum, the cerebellum, and the brainstem. The answer choice is D. Number 84. You are caring for a 70-year-old female with signs and symptoms of an acute stroke. She is conscious, has secretions in her mouth, and is breathing at a normal rate with adequate depth. What should you do? The answer would be A. It's the only answer choice that includes suctioning, and we know she needs to be suctioned because of that phrase, she has secretions in her mouth. That's a dead giveaway. Number 85. At the scene of an automobile crash, a utility pole has been broken and power lines are lying across the car. The patients inside the car are conscious. What should you do? Yeah, I mean, without even looking at the answer choices, you know for sure you shouldn't do anything that gets you close to that car, right? They could be live. You always need to assume power lines are live, so the only choice that makes you not be anywhere near that car would be D. Number 86. You are assessing a 33-year-old male who complains of severe abdominal pain, weakness, and nausea. He tells you that he was gathering wood to build a fire when he felt a sudden, sharp pain on the back of his hand. Your assessment reveals that the patient's abdomen is rigid and painful to palpation. What should you suspect?
I would see because he says wood, and spiders that are in wood are usually brown.
Okay, so that's not a bad first instinct. So you're thinking wood, so you're thinking a spider that was living in the wood pile or whatever he was gathering wood from, the forest somewhere. We know it's not Rocky Mountain spotted fever because we kind of talked about that in a previous question, and it doesn't act like this at all. We talked about how it's a lesion and it turns into a rash and it takes several days from a tick bite. It's not this kind of relatively immediate response. Envenomation from a pit viper, that's a fairly venomous type of snake, or it's a class of snake. And you would definitely expect a reaction, but it would just be different. You wouldn't have this sharp pain. They probably would have said something about seeing very clear bite marks because snakes have a very clear, distinct look to their bites. It just doesn't really seem to match. So yeah, it's definitely a spider thing. Now the question is here that you have to know, what does a brown recluse spider bite do versus what does a black widow spider bite do? Does anybody know what happens with a brown recluse spider bite? You can. That's not so much an issue. What really happens that you should be aware of with the brown recluse bite is where you see the tissue dying near the bite. Talk about necrosis of tissue. The venom acts locally first. So you'll see the very distinct like bite area. After a few days, you can look this stuff up online and kind of see like a progression of pictures. But after a few days, you'll have kind of a pit there. And essentially that will continue to spread. The flesh literally is being rotted away by the poison from the brown recluse. On the other hand, the black widow spider bite, does anybody know how that attacks? It doesn't attack locally. Anybody know? It's a systemic attack. It'll attack the nervous system. So in this case, is he having more of a local or more of a systemic response? More of a systemic response. He's got abdominal pain, weakness, nausea. Those are sort of general things that would happen to somebody. We're not seeing that specific response that we would expect with the brown recluse spider bite. So in this case, the answer is A. We are assuming he was bitten by a black widow, which would have essentially this kind of reaction. Number 87. You respond to the residence of a 62-year-old male who is unresponsive. Your initial assessment reveals that he is pulseless and apneic. What should you do? The answer is A. So this is going back to when y'all did CPR. We talked about the chain of survival. Remember those parts of the chain? We're talking about early recognition of a heart attack, early EMS activation, early CPR, early AED, or maybe mixing some of those up, early transport to the hospital, and early, or it's not really early, but just the advanced care alongside, like continuing. So in this case, that early CPR, early AED, you want to get those going as quickly as you possibly can. That's what you know to do to treat somebody who's having a heart attack. As a basic, that's pretty much all you can do. You do want to transport, but you want to get that AED on them. Remember, for adults are probably going to need the AED. Children may be able to be resuscitated with just CPR, because usually their heart has stopped because of a breathing problem. So hopefully if you get them some oxygen and start working on it, they can kind of come back a little bit easier. Adults, their heart muscle has been going for however many years they've been alive, and it's pretty tough, and it usually needs a little bit more, so the AED is almost always necessary. Number 88. A 19-year-old female is found unconscious by her roommate. Your initial assessment reveals that her breathing is inadequate. As you insert an oropharyngeal airway, she begins to gag violently. What should you do? B is correct, yes. Remember contraindications for an OPA. If somebody has a gag reflex, that's a main contraindication. You can't put it in because they're not going to tolerate it. Since she's gagging, she does have a gag reflex, so you have to remove the airway and try something different. Why would you need to be prepared to suction her oropharynx? Okay, in case she throws up, yeah. Gagging can produce a lot of saliva. It can even make you vomit, so you want to be prepared for that in case that happens with your patient. Number 89. A 3-year-old female ingested several leaves from a plant in the living room. The child's mother is not sure what type of plant it is, stating that she bought it simply because it was pretty. After completing your initial assessment of the child, what should you do? C is the correct answer. You want to contact your regional poison control center. If you knew what the plant was, and it was something that you knew how to treat, maybe you would give activated charcoal. You don't use Ipecac. We don't use Ipecac on the ambulance, so that's totally off the table. And transport isn't a bad idea, but specifically here, you can talk to somebody. The regional poison control centers are always the way to go when it's a poisoning that you don't immediately know how to treat. And number 90. When caring for a 65-year-old male with respiratory distress, you place him in a comfortable position but do not apply oxygen. The patient's condition continues to deteriorate, and he develops cardiac arrest and dies at the hospital. This scenario is an example of what? In this case, the answer is C. So, what is negligence? Do you all remember the definition from the book?
It's like you don't do what you're capable of to do.
Yeah. So if you're negligent, first off, you have to have a duty to act, which means, if you were called in as an EMT, you have a duty to act. You have to have breached that duty, basically not done what you were supposed to do. And then also to count as negligence, that breach has to have led to harm to your patient. So in this case, obviously it did, right? What would be our standard of care for a patient in respiratory distress? To apply oxygen. Like, we do that to every patient, let alone one who specifically has respiratory distress. Because you didn't perform up to your standard of care, you had that duty and you didn't do it. It was a breach of your duty, a breach of your normal standard of care. And so because that caused harm to the patient, it's negligence. Remember, abandonment is when you leave a patient basically without ensuring that they're continuing to receive the same care or better. Like if you were to just take a patient and dump them in an ER waiting room versus hand them off to a nurse or a doctor and give a full verbal report. And assault and battery both would have to do with if you actually physically interacted with the patient. Battery specifically is like physical violence, and assault is a threat of physical violence. It doesn't necessarily include the physical contact, but neither one of those really applies here. So the answer is negligence. 91. Despite your attempts to coach a conscious young female's respirations, she continues to hyperventilate with a marked reduction in tidal volume. What should you do? So when you've got a patient who's hyperventilating, what does that mean? Breathing very fast, yes. And we also know she has a marked reduction in tidal volume, so she's breathing very shallowly and very fast. And even though you're trying to talk to her, it's not working. So yes, the answer is C. Explain to her that now you're going to assist her ventilations, which means essentially that you'd want to do the BVM ventilatory assistance, and of course you'd want to explain to her first and make sure you have her consent for that. You don't want to restrain her. Giving an NPA doesn't make any sense at this point. And you certainly wouldn't want to ventilate her at the rate at which she's already breathing, because she's breathing too fast. We're supposed to slow that down. What's our range of respirations that we want? 12 to 20 is ideal for an adult. It says she's a young female, so we don't really know. It's, the range is slightly higher for an adolescent or a child, right? Remember, babies breathe faster, heart goes faster, blood pressure is lower, and as they start to age, their numbers begin to get closer and closer to adults. So if you don't remember all of your pediatric and adolescent charts of vital signs, I would suggest spending some time looking over in the book, and also just kind of generally understand approximately where those ranges should be. Like, even if you don't remember the exact number, if you at least remember that a 5-year-old should be breathing faster than a 50-year-old. Like, that's a good start, basically. 92. As you and your partner are carrying a stable patient down a flight of stairs in a stair chair, you feel a sudden, sharp pain in your lower back. What should you do? B, yes. Stop the move. Request additional lifting assistance. A is only going to hurt you further. C doesn't really help you either. You're continuing to still move the patient. And D is absolutely wrong. You never, ever, ever just let a patient walk anywhere. If you have to carry them, like you were obviously putting them in a stair chair to carry them down the stairs, you're not going to let them get back up and walk because, oh, hey, my back's hurting, you got to walk now. That's not how it works. 93. 2 EMTBs witnessed a call in which a coworker gave adequate medical care but ignored the patient's emotional needs. The coworker was deliberately rude solely because the patient was thought to be infected with the human immunodeficiency virus, HIV. The EMTBs ignored the coworker's treatment of this patient and took no steps to prevent this behavior from happening again. This lack of action on the part of the 2 EMTBs is considered what? Okay, so was it ethical for the patient, for the original coworker to ignore the patient's emotional needs? And was it ethical for his coworkers to ignore that he had done that? No, so certainly unethical. Talking about legal, did the coworker fall down legally in any respect? He gave adequate medical care. So he ignored the patient's emotional needs, but he cared for what he was actually supposed to care for. We talk about how we are supposed to first care for medical and emotional needs. From a legal standpoint, the medical needs are what we're trained to do. That's what our equipment is based upon. That's what our standard of care is based upon. If you were found to be grossly hurting somebody on purpose from an emotional standpoint, there could definitely be problems. But from a legal standpoint, that's not really taken into account the same way. So the answer here is B. What they did was legal. They didn't have any legal requirement to report this mistreatment or rudeness, I guess. It's not really mistreatment. They didn't have any legal requirement to report the rudeness, but they certainly should have from an ethical standpoint. Number 94. A 19-year-old female was stung multiple times on the legs by fire ants. She states that she is allergic to fire ants, but does not have epinephrine or an anakit. The patient is the patient is conscious and alert and complains of pain to the area of the bites. Her blood pressure is 122/70, pulse is 100 beats per minute and strong, and respirations are 18 breaths per minute and unlabored. What should you do? Okay, so let's go down the answer choices. A, should you position her legs well above the level of her heart? Why not?
Even though she's most likely to go into shock.
Okay, so yeah, we talk about how the Trendelenburg position, which is that legs up kind of thing, that's for shock. But also in this case, remember, she got bit on the legs by fire ants. Now we talk about how we're supposed to use gravity to our advantage, not our disadvantage. And having the legs well above the level of the heart is going to basically aid the poison, the venom or the toxin from the fire ants in moving down towards her heart. She says she's allergic. She's not having a major reaction right now, but still, you want to avoid that. There's no good reason, medically speaking, to put her legs well above the level of her heart at this point. B, administer oxygen and transport her to the hospital. Anything wrong with that one? Okay, that's a good solid choice. C, request a paramedic unit to administer epinephrine. Okay, so there's a number of things wrong with it. Yes, it would take a while. Yes, you would need to call medical control if that's what you were going to do. But honestly, if you look at her vital signs, does she need epinephrine? Okay, no. When do we give epinephrine? Specifically, we give epinephrine when somebody's having anaphylaxis, an anaphylactic reaction, which is talking about difficulty breathing. We're going to see that blood pressure shoot way low. Remember, because it's a kind of shock. Are we seeing either of those responses? No, her blood pressure is right in the normal ballpark range. Her pulse is a little bit fast, why does that make sense in this case? Why would her pulse be fast reasonably? Yeah, she's scared and she's in pain. And both of those are reasons why your pulse would be a little bit higher than what might be normal. Her pulse isn't super fast, though. We're not talking like 180, where it's 100 beats per minute. So it's on the higher side of normal, but still in the normal range. Respiration's 18 breaths per minute and unlabored. Again, that's good. 18 breaths per minute is well within the normal range, and she's having no difficulty. So even if she was prescribed epinephrine and she had an EpiPen on her, it would still be inappropriate to give her epinephrine or to give her an EpiPen at this point because she doesn't need it. So remember, don't automatically assume if it's an allergic reaction type question, don't automatically go for epinephrine every single time. You're going to have questions like this. I can guarantee there's going to be some on there. Maybe not for every person because the questions are always shuffled around, but there are questions on the test that are like this, where they give you a whole bunch of signs, a whole bunch of vital signs, but they don't actually point to what you would think of as the typical required intervention. And then do we do D, ever? We don't ever, for at least for the question's sake, you're never going to have a question, like Randy said, where you don't transport your patient. That's never going to be an option. So the only answer here that even is remotely right is B, and B is a good answer. Number 95. You are ventilating a patient with a stoma. However, air is escaping from the mouth and nose. To prevent this, what should you do? First off, what's a stoma?
It's a little like breathing.
Yeah, so they've opened up into the trachea, into the neck. Remember, they go through the cartilage right here to have an easier access airway, because for whatever reason, they've had problems with breathing normally through their nose and mouth. Maybe they had jaw cancer or something else that makes that not very easy, but for whatever reason, they have a stoma. So if air is escaping from the mouth and nose, what would you do? Okay, so what is A talking about? We'll just go down through the answer choices, since I'm hearing a lot of different options from the class. What is A talking about? Thrusting the jaw forward? That'd be the jaw thrust maneuver, and when do we do that?
When they have an injury or
So when we suspect spinal injury, but we still have to open the airway. That doesn't apply here, right? It's not going to do anything about the escaping air. Seal the mouth and nose.
would that make it worse when you cut off their ball?
Okay, we'll look at the question. You're ventilating a patient with a stoma. If a patient has a stoma, how do you ventilate them? Through the stoma, right? Because we're assuming that something is going on with the nose and mouth, that they can't breathe normally through the nose and mouth. So you don't care if air's, you don't need air to be going in and out of the nose and mouth, right? Now, why would it be bad that air is escaping from the nose and mouth at this point? Because, yeah, exactly. You're blowing in through the stoma, but instead of all of it going down into the lungs where it can be used, some of it's going down, but some of it's also coming up and just escaping straight through the mouth and nose without ever going into the part that actually needs it and can use it. Okay? Based on that, would sealing the mouth and nose have any benefit? Okay, what would that actually do for you, or for your patient, excuse me? Yeah, so if you're sealing the mouth and nose, all of a sudden that air can no longer escape up, and it all has to be forced down because there's nowhere else for it to go. So B is actually the correct answer here. B is a perfectly fine answer. It's not going to hurt them at all. Remember, you're ventilating through that stoma. Their mouth and nose are essentially useless for what you're actually doing right here with this patient.
How do you seal the mouth?
You could do it with like your gloved hand if necessary. You don't want to put any like pressure onto their face. It would really depend on what their face looks like, or if they've got any conditions. Like, we don't know why they have a stoma, like I was saying. So it may be cancer or something else that is making them not able to breathe normally through their mouth. But you just want to seal it with, like I would say, probably a gloved hand is the easiest way to do it. Like pinch the nostrils, kind of work with what you got for your patient. Number 96. A 60-year-old male presents with acute respiratory distress. He is conscious and alert, has pink and dry skin, and respirations of 24 breaths per minute with adequate depth. Which of the following treatment modalities is most appropriate for this patient? Okay, so when looking at this question, look at his vital signs. This is kind of like that anaphylaxis question we had just like 2 or 3 ago. His vital signs are pretty much within the range of normal, what we know about them. So he's conscious and alert, that's good. Pink, dry skin, what does that tell us about his perfusion? He's got good perfusion. So he may be in respiratory distress, but he's still getting enough oxygen, and his heart is beating well enough to get that oxygen out to his skin, his extremities. Respirations of 24 breaths per minute, a little bit fast, right? So that typical range is supposed to be 12 to 20. So 24 is slightly outside of that. It's not yet what I would consider where you actually need a BVM. We talked about that, I think, a couple periods ago. I would say probably in the question, if they give you 30 or that their respirations are 28 or 30 or higher, that's when you want to use the BVM to purposefully slow them down. If they're giving you If they're giving you those kinds of numbers, anything less than that, even though it might be higher than what would be typical, 24 is still okay. You don't have to actually ventilate for them. So, I mean, yeah, I just said definitely not A, and nobody said C out loud, so really we're looking between B and D, right? And both of them are reasonable answers, I guess. They kind of both look nice. The answer is supposed to be B. So your patient has acute respiratory distress. That means that even though he's got an adequate rate of respirations at an adequate depth, he is having trouble breathing. We don't know anything about his positioning or anything else, but we can probably safely assume that he's got labored breathing, that he's having difficulty actually getting those breaths in. You might be seeing that like tripoding type position that's very common in respiratory distress. Based on all of that, we want to go ahead and treat for what we're seeing right now. A non-rebreather is going to give a whole lot more oxygen than a nasal cannula. And so we just want to attack that now instead of give him something small. Prepare for the worst, essentially, or prepare for the more extreme case. His vital signs aren't going to stay this good if he stays in respiratory distress, basically. So we'd rather help him out now. Does that make sense? Number 97. A 40-year-old male was stung by a bee and is having obvious signs of a severe allergic reaction. He tells you that he has an anakit in his car but has never used it before. As your partner applies oxygen to the patient, you contact medical control. The physician will most likely advise you to what? Okay, now I know we don't use anakits. I don't know why that's a thing that this particular testing question group continually uses, because we always use EpiPen. So all of these questions that deal with anakit or epinephrine are a little bit off for us. We don't ever just give a straight dosage out of a vial. However, assuming that we're talking about giving somebody epinephrine out of an EpiPen, what is the dose of that? Yeah. So even though you would never see a question like this, you might see a question asking you about the dosage of epi that you're giving in an EpiPen, and in that case you should know that it's 0.3 milliliters, which is D. Number 98. During your attempts to dislodge a complete upper airway obstruction in a 30-year-old male, the patient becomes unconscious. What should you do? Yes, the correct answer is C. So this would be something that you might remember from when we were talking about CPR and choking way back at the very beginning of class. If you have a patient who is choking, has some sort of airway obstruction, if they're coughing still, what do you do for them? You encourage them to cough, but you don't actually want to touch them because their body's still able to function and do something. What if that becomes a complete obstruction and they're not choking, they're not coughing, they're not breathing, absolutely no air is moving in and out? You'd start, I don't think they call it that anymore, but it's those abdominal thrusts. Yeah, that has a different name now, or maybe they do it slightly differently. But essentially it's the same thing you've always learned as the Heimlich maneuver, those abdominal thrusts. I should say that also includes if they're coughing, but their cough is so weak. Like, some people who have respiratory problems anyway won't be able to cough strongly enough to get it out. My grandmother, towards the end of her life, she could barely breathe, let alone cough, and her cough sounded like, I don't know, like nothing. It sounded like a cat sneezing or something, like very, very, very soft. And so for her, letting her try to cough it out would have done nothing for her because her body was never, ever able to get enough force in the lungs to actually push something out. But in most cases, if somebody's coughing, you let them cough. If somebody becomes unconscious while you're doing those abdominal thrusts, what do you start to do?
You put the sweat and you start.
Yeah, you'd lay them on their back and you'd start doing CPR on them at that point. Because at that point, they are unconscious and they are apneic. And that leads us towards essentially CPR. CPR is going to have the double benefit of helping keep their heart going, but it also is providing a similar type pressure to what you were doing with your abdominal thrusts. If y'all remember when you're doing those thrusts on a lady who's pregnant or a person who's really, really large and you can't properly get your arms into the right position to where your hands are just above the navel, you're actually supposed to reach up around their chest and deliver chest thrusts from behind, just like you do with the abdominal ones. But because for positioning reasons, that's what you can do. And it's not as good as actual abdominal thrusts, but it's better than nothing. So CPR is kind of playing both roles. It's giving you those chest thrusts, and it's also helping with the heart a little bit, because I can guarantee you that if they're unresponsive and apneic, eventually they're going to be pulseless as well. Number 99. You are transporting a 49-year-old male with chest pain and an extensive cardiac history when he suddenly loses consciousness. What should you do? So this is one of those questions that has kind of a couple red herrings in it. We know about chest pain, we know about an extensive cardiac history, which would make you start thinking maybe to put on the AED or to do something with the heart. But in reality, when you're treating a patient who loses consciousness, what do you start with as far as your the way you treat them?
Airway.
Yeah, you do your ABCs, airway, breathing, circulation. So airways at the top of that, open up their airway first and foremost, and then you move on to everything else. This is one of those where there's a lot of good choices, but you have to think literally what is the absolute first thing you would do. And number 100, and we'll take a break. At the scene of a mass casualty incident, you identify a patient as an organ donor. When triaging the other patients, what should you do? Okay, so when we talk about triaging, what does that actually mean? Yeah, so triage, those of y'all who've spent time in triage in the ER, triage is evaluating patients and on a very, very basic level to try to determine who needs care the most. It's used when you've got multiple patients, like in an ER, where you're going to have somebody coming in with the sniffles sitting right next to somebody who may be having a heart attack or a stroke. People who come in, they have to get triaged so that we know who's got something worse, because you want that person with a life-threatening condition to be seen before you, even if, you have a cold, it's nothing like the same thing as what they're going through. Also, in a mass casualty incident, like, say, multiple vehicle collision, a poisoning, lots of things. A good example from recently would be when that drunk driver crashed into that big crowd at South by Southwest. Did y'all remember hearing about that? I think there were like 3 that died, or maybe 2 that died on scene and another 20 injured, and at least 1 more died in the hospital. They would have had to triage all those people to decide the difference between the people who were in really, really critical condition and the people who were just the walking wounded, is what they're called. So when you're triaging, you have, it might be classified different ways by different books, but essentially you have a few basic categories. Highest priority people are people that you can actually help. So let's say you have a patient who is unconscious, not breathing, pulseless on the ground. And then you have a patient who is conscious, has a femur fracture, and is crying loudly. And you have a patient who has a broken arm and is kind of walking around seeming a little bit dazed. And you have a patient who's just sitting there texting on their phone like nothing happened. Which patient has the highest priority? The femur fracture, okay? Because that is the person that you can most help. The most severe thing that you can help, let me put it that way. Patients who are unconscious, apneic, pulseless, that kind of thing that you typically think, wow, they really need a lot. In a mass casualty incident, they're actually at the very bottom of your list. Even after the walking wounded, like that person with the broken arm, because there's not much you can do for them. They're going to take a lot of your resources and a lot of your time, and in the end, you probably won't be able to help them very much. You want to focus your energies and all of your efforts and resources on people that you can actually help. When you are triaging people, does whether or not someone is a donor, an organ donor, make any difference? Absolutely none at all. If somebody is an organ donor, it doesn't make a difference in terms of who you're actually helping that day. It'd be ideal if, you could somehow make everything work, but you can't. And so we just can't kind of take that into consideration when we're doing this. So based on that, what was the answer? What would the answer be? The answer is B. Yes. You may have to assign them a lower triage priority based on their actual injuries, not based on their donor status. Like I said, it just doesn't come into account at all. So you don't transport them first. You don't assign them the highest priority regardless of injuries. And you're certainly not going to dedicate an entire separate ambulance just for that one patient. You're going to treat them like you would anybody else. Hopefully they survive. Hopefully everyone survives. But that's how you have to do that. And we're going to take a little bit of a break. Question number 101. During your assessment of a 6-month-old male with vomiting and diarrhea, you note that his capillary refill time is approximately 4 seconds. From this information, you can conclude what? Okay, so vomiting and diarrhea, what does that tell you about your patient most likely? You can probably assume that he's dehydrated, yes. Capillary refill time, what is that used to determine? Yes, their blood flow. And what is the more fancy word for blood flow? Okay. Yeah, specifically I was actually going for perfusion. Perfusion is talking about blood flow through all the capillaries. Circulation is more the general term for how your blood flows through your body. So you want good perfusion. And if somebody's peripheral perfusion is decreased, what does that mean? So in their extremities, right, in fingers, toes, things like that, anything that's not in the core of the body, they don't have as good of blood flow. Would you expect to see a longer or a shorter capillary refill time in somebody who has poor peripheral perfusion? Longer, right, because what is capillary refill time measuring? Yeah, well, you're looking for less than 2 seconds. What you're measuring is essentially how long does it take for blood to flow back into the capillaries if you squeeze it all out. So if you put pressure on, say, the fingertip, and you squeeze all the blood out of the fingertip, out of all the capillaries in the fingertip, if you let go, it should take less than 2 seconds for the blood to normally refill and come back to a more normal color. If it takes more than that, they don't have very good perfusion, which makes sense because we also know that this kid is dehydrated, right? If you're dehydrated, that means you probably, along with having less water in your blood in a general sense, what does that mean about the volume of your blood? Okay, so your blood's probably going to be thicker. You're probably also going to have less of it overall because your body's trying to compensate all over with this whole dehydration thing. And so it's pulling water from wherever it can get it to try to kind of balance out and make sure that, you know, the kidneys have some and the stomach has some and the blood has some and everything like that with your patient. So your patient is probably hypovolemic, meaning low blood volume, as well as dehydrated. Both of those make sense with a longer capillary refill time. And therefore the answer is C. We don't know anything about his respiratory status, right? We don't know anything about his blood pressure. And we don't know anything about his skin temperature. None of those are really addressed anywhere near as clearly. Capillary refill time is specifically dealing with perfusion, so it's a really clear connection there. Number 102. An 81-year-old female fell and struck her head. You find the patient lying on her left side. She is conscious and complains of neck and upper back pain. As you are assessing her, you note that she has a severely kyphotic spine. What is the most appropriate method of immobilizing this patient? Before we even get into this question, I want you to note one particular word, kyphotic or kyphotic, depending how you hear people say it. Do you know what that's referring to? There's a condition called kyphosis. Specifically, it means a bent forward spine. So not necessarily somebody who has a hunchback, just somebody who has a very pronounced forward bend to their spine. So that is kyphosis. If you have a patient who has kyphosis, especially a severely kyphotic spine, do you think it will be comfortable for them to fully straighten out their back on a backboard? No. So you have to think of something different. Well, actually, first of all, does this patient need a backboard or whatever, some sort of spinal device? Yes, because she fell and she struck her head. She's complaining of neck and upper back pain. So we're going to go into this with the assumption that something with her spine is a little bit messed up. We don't really know what yet, but we're certainly not going to ignore that. We have to do something, and we know we can't immobilize her straight to a backboard like we would most patients.
Can you have that padding?
Okay, so padding would be good. So based on everything we've talked about, let's look at the answer choices now and see which one makes sense. A, apply a cervical collar and place her in a sitting position on the wheeled stretcher. No, you don't have a patient with a back injury sit up. That's a cervical collar is going to help make sure that her neck doesn't move around too much and help support her head, but it is certainly not really immobilizing her neck fully. That's why even on a backboard, we have to still strap their head into the backboard because the cervical collar only goes so far. And we don't know anything else about immobilizing here, so that's clearly not enough treatment for the whole neck, back, head thing. B, immobilize her in a supine position on a long backboard and secure her with straps. No, that is what you would do for a typical patient, and this is an atypical patient. Atypical is in a non-typical patient. You do not want to do that to her because we know what's going on with her back. C, leave her on her side and use blanket rolls to immobilize her to the long backboard. Maybe. Okay, those blanket rolls could be the padding that you were talking about to kind of fill in the gaps and hopefully put around her enough that she would be immobilized. D, move her to a supine position and immobilize her with a scoop stretcher and padding. Yeah, we already talked about her. Move her to a supine position isn't going to be great. She has a severely kyphotic spine. You're not going to have enough padding and enough straps and everything to properly immobilize her in a supine position. Yeah, and also a scoop stretcher is not indicated for this. Scoop stretchers, we use them, remember, for somebody who has a broken hip or pelvis. We talked about that on the last class. There's no indication that we need that kind of equipment here. So the answer would be C. Leave her on her side and use blanket rolls to immobilize her to the long backboard. There's nothing in that answer that's incorrect, and based on what we know about our patient, it's the best way to deal with it. Number 103. You are dispatched to a residence for a 56-year-old male with an altered mental status. Upon arrival at the scene, the patient's wife tells you that he complained of chest pain the day before, but would not allow her to call EMS. The patient is semi-conscious, has rapid and shallow respirations, and has a thready pulse. What should you do? Okay, so everyone has hit on oxygen therapy, basically, right? Because we have our ABCs that we need to deal with, and vital signs go way down on the list, and we don't really know that that he needs an AED yet. He has a pulse, he is breathing, he is semi-conscious. An AED is not indicated currently. So we have either ventilatory assistance, which would be a BVM, or a non-rebreather. And show of hands real quick, who thinks a BVM is more appropriate? Who thinks a non-rebreather is more appropriate? Okay, the actual answer would be BVM. Looking at his respirations, they are rapid and shallow. There's no indication that that would be adequate. You don't want to see, because what you're probably seeing is quick, small breaths that's not really giving enough oxygen when it comes in, and they're not staying in for long enough to really give the patient a whole lot of oxygen. Additionally, every time they breathe, they're breathing out their carbon dioxide, which is good, right? We don't want carbon dioxide, but it also can cause problems because we have a respiratory drive that is driven by carbon dioxide. Too much carbon dioxide in the blood, and you breathe, and that's how it's supposed to work. If you're having problems and you're breathing way too fast and shallow, you're having problems on both ends. Not enough oxygen, not enough carbon dioxide is going to cause problems in your body. So you want to go ahead and get them on something to have that ventilatory assistance and get them to a more adequate level of breathing. Number 104. Substance abuse is most accurately defined as what? The answer would be D. This is straight up facts. Substance abuse is knowingly misusing a substance to produce a desired effect. It is not selling drugs, it is not unwittingly consuming drugs, and it is not using a therapeutic drug, as in a drug that is like prescribed to you, to treat the illness it's prescribed for. That's correct use of a substance. So the answer is D. Number 105. You have been tasked by your medical director to assist in the development of your EMS agency's institutional standards. When developing these standards, it is important to what? So let's just go down this answer by answer. A says, require personnel to transport all patients to the closest hospital. Okay, so on the surface it kind of sounds good. Yes, you want to transport them somewhere close, but the literally closest hospital may not be always best. You also have to look at the resources the hospital has, the type of training and facilities they have. If you were to be out here and try to take a severely burned patient to Dallas Regional just because they're closer, they would turn you away at the door and say, no, go on into Big Baylor in Dallas because they don't have a good burn unit. Or they'd even send you to Parkland. They'd send you to somewhere that has an actual burn unit and can treat that because it's very specific and not every hospital is equipped to do that. Trauma centers are divided, like every hospital has an ER as a trauma center. They're divided into classifications. And if somebody really requires a certain level of care, you don't want to take them to a lower level because they're just not going to get the right kind of care there. It's not a fault of the doctors or the nurses. It's the actual facility doesn't have the equipment or the resources that are necessary to treat that issue. So the closest hospital is not always the best choice, and you wouldn't want that to be a requirement. What about B? Be reasonable and realistic to avoid overburdening your personnel. That could be good. We don't see anything wrong with that one yet. Okay. C, demand that all personnel consistently exceed the standard of care. The key here is consistently exceed. Okay, so what is your standard of care? When we say that phrase, what are we talking about? Yeah, so your standard of care is basically your general best practices that everyone follows. When we talk about it from a legal sense, we're talking about that's what you do and that's what another person equivalently trained would do. Any other EMT that you looked at should be doing the same thing that you're doing. It is based on technology, based on equipment, training. That is the best way that we know how to deal with a problem. So standard of care, that's things like giving oxygen to a respiratory distress patient, giving nitroglycerin to a patient with chest pain who's been prescribed it. These are things that we know how to do, and they're what we should do because that's the standard. So the standard of care is a good thing, but should we always demand that they consistently exceed it? That's essentially saying you always have to do better than the best. Okay, so if you're exceeding standard of care, you're telling your people to do something that they may not have the equipment or the resources to do, and they may not have been trained for. That's why we have that standard, so everyone knows that you're going to get the same thing wherever you go. And you can't just assume that people are able to go above and beyond that. And then D, expect personnel to function beyond their scope of practice if needed. Absolutely not. Scope of practice is what it is. You do certain things that you are trained for, and you do not step outside of that. It becomes a real legal issue when you step outside of that and try to do something different. If you run an ambulance and put in an IV as an EMT basic, that'd be a huge issue if you weren't authorized to do that, hadn't been trained to do that. Some ambulance services, their medical director does authorize to do that, but then again, that becomes part of their scope of practice. Going beyond their scope of practice would be doing something they're not trained to do, and so that's absolutely not okay. So based on that, the only answer choice here that is at all okay is B. And B is good. Be reasonable and realistic to avoid overburdening your personnel. You want it to be up to the standard of care. You want to clearly identify the scope of practice. But B is the most correct answer. Number 106. You arrive at the scene of a domestic violence situation. As you approach the doorway of the apartment, you hear screaming and the statement, "He has a gun." Your most appropriate action should be to what? The answer is D. Definitely don't go into the apartment. So both A and B are absolutely wrong. It is not your job to try to clear an apartment from a guy who has a gun. That is law enforcement's job. Why is C not as good of an answer as D? Yeah, because C says nothing about your patient or securing the scene. It's literally like you drive away like nothing happened. It doesn't have anything in there about notifying the police or your dispatcher or anything. And so it's not a complete answer. Yes, you want to get in your ambulance, or at the very least get somewhere safe. Your ambulance is probably a good safe place. But you don't want to just run away from that. You have to actually deal with that situation and get the police involved. Number 107. A 67-year-old female presents with difficulty breathing and chest discomfort that awakened her from her sleep. She states that she has congestive heart failure, has had 2 previous heart attacks, and has prescribed nitroglycerin. She is conscious and alert with adequate breathing. Her blood pressure is 94/64 and her heart rate is 120 beats per minute. Treatment for this patient includes what? Okay, so would you give nitroglycerin? Why not? She has prescribed nitroglycerin. Why would you give it to her? So what is that number, that magic number that has to be? Yeah, you have to have systolic of 100 or more to give nitroglycerin, regardless of whether or not it's prescribed. Well, you wouldn't give it at all if they don't have it prescribed. But you wouldn't give it, even if it is prescribed, if that number is below 100. And in this case it is, it's at 94. So A is out. The other 3, we've got 2 that deal with oxygen, and then what is D talking about? Why is D even a choice on here? Okay, so it would help her breathe, right? So again, it's sort of talking about airway breathing related stuff. So really all the other 3 choices are talking about airway and breathing. And at this point you have to choose which is the best treatment for this particular patient. So what do we know about her treatment? What do we know about her breathing? Excuse me. She has difficulty, right? Kind of a general statement. She has chest discomfort, which could sort of relate to that. It's probably pointing more towards a heart attack or something. She has congestive heart failure. What does that mean? When we talk about congestive heart failure, what is actually happening to the heart? It's weak and it's not pumping well. The muscle's not actually dead or dying necessarily, but it is not functioning properly. So this makes sense because she says she's had 2 previous heart attacks, and in each of those heart attacks her muscle was probably weakened, which means now that it's trying to beat, but it's not beating well. So we've talked a little bit about CHF, but I know it's been a while. Remember, the heart has a left and a right side. Okay, so if you have right-sided CHF, that means the right side of your heart is not pumping properly, so blood is going to back up, okay, because it's not able to go through smoothly. It's going to back up. Where will it back up to if it's right-sided weakness? Right-sided in general, so not atrium ventricle, but where does the blood come from that goes into the right side? The body as a whole, okay? So remember, when we're talking about blood, the arteries carry blood out, veins carry blood back into the heart, and they enter through the right atrium, and then right ventricle, whatever. So if the right side is weak, all the blood that's trying to come back in through those veins is getting backed up into the veins. That's when you see things like JVD, okay? Because those jugular veins, which normally wouldn't be full of blood because it'll be going into the heart regularly, they're getting backed up and full of blood, and that's why you see those clearly. Remember, we showed those pictures. That's what happens. Other things that you'll see with right-sided CHF, you've got fluid backing up into the body, so you're going to see edema. You're going to see pedal edema, which means what? Yeah, your feet, your lower extremities. That edema is talking about swelling. It's talking about liquid or fluid building up in the body. And you're going to see that where gravity acts. So it's going to be going down towards your feet or lower extremities in general. That's right-sided CHF. So if you have left-sided CHF, same thing is essentially happening. The heart on the left side now, atrium, ventricle, whatever, is weak and not pumping through properly. But where is that blood backing up to? The lungs, okay? So if you have left-sided CHF, the blood that should normally be pushing through and continuing on is still backing up, but it's backing up into the lungs, which is where it just was. Because remember, right side leads to lungs, leads to left side, and then back out to the whole body. So if you have a patient with left-sided CHF, what would you expect to see as signs or symptoms with your patient? Definitely difficulty breathing, right? Because there's that fluid in their lungs. Any other ideas? Just like you had pedal edema for the other one, you're now going to have pulmonary edema, which is fluid in the lungs, okay? You might see kind of a pink sputum when they cough up, meaning that like the mucus or the things that they cough up is going to have a little bit of a pink bloody tinge to it because that blood is sitting in their lungs, and it's going to some degree be able to pass through and come out when they cough, all that fluid. That's kind of the main stuff with CHF. So not only does your patient have difficulty breathing specifically right now, but she has CHF. And we don't know which side, but it's probably fair to say that because her heart's affected, her breathing is impacted. CHF is not always clearly like right side versus left side. It can be the entire heart in general. You can have both at the same time. So we don't know exactly what she has, but it's safe to say probably that she does have some fluid in her lungs at this point. With CHF and 2 previous heart attacks, she probably has some of that pulmonary edema, okay? People who have CHF often have to have a CPAP machine. It's one of those positive pressure machines that actually pushes oxygen in because all that fluid that's in their lungs is holding their alveoli closed. And they have to push in enough pressure to pop open the alveoli whenever the oxygen comes in so their body can actually use it. Because if the alveoli stay closed from all the pressure that's exterior to them, they just never fill up and you can't use oxygen because it's not getting anywhere good. Okay, so that's CHF. I know I gave you a lot there, but it really does relate to breathing, and you need to understand how it all kind of hooks together. Okay, congestive heart failure, difficulty breathing. She's conscious and alert with adequate breathing, is what we're told. So at this moment, she does actually have... Hold on. So at this point, she does actually have adequate breathing going on. Based on that, which one of these can we disqualify, B, C, or D? Sorry? B, because she doesn't need a BVM at this point. She has adequate breathing and she's conscious and alert. Difficulty breathing, sure. She needs something, but not a BVM at this point. So since we know that a BVM is totally out of the question, it's not necessary for this patient, we have either oxygen via nasal cannula or placing her in an upright position. Based on what we know about her, all of her history, her current signs, symptoms that we've talked about, which one of these would help her more? Okay, you could make arguments for either one. In this case, I chose D. Remember we talked about how that CHF causes fluid to build up in the lungs, and she has difficulty breathing. Placing her in an upright position is going to help use gravity, we've talked about quite a bit, help use gravity to keep that fluid from making it even more difficult to breathe. If somebody with CHF is sitting up, it's better than if they're laying down. It can feel like they're drowning in their own skin because the liquid, the way it spreads out, it closes even more of the alveoli, which is the main problem with this sort of thing. The reason why I would say not C, despite the fact, D is good, but the reason specifically why I would say not C is that I wouldn't put her on a nasal cannula. Remember we talked earlier about that patient who had adequate breathing and we were trying to decide what was the best way to give them oxygen. Non-rebreather in that case was the better way because even though they had adequate breathing, they had signs that there was going to be problems on down the road. So I would give a non-rebreather. Because of that, C is incorrect because a nasal cannula, while it's oxygen, is really not going to help all that much. So even though you might think oxygen, yes, let's do oxygen. In this case, I would do D. I would put her in an upright position, but I wouldn't actually technically do C. I would do something similar, but use a different mechanism, use slightly more oxygen. And in that case, C becomes less correct than D. Does that make sense? Sometimes you kind of have to think around a problem. Once you have in your mind that they all have to do with airway breathing, it really just comes down to what would you do for this patient, and then how does that match up with what the options are? If you get too bogged down in what the options are, sometimes you'll think, oh, it mentions oxygen. It's the only one that specifically mentions oxygen. It has to be correct. And that's not always the case, because if they all have to do with airway breathing, you want to consider them all sort of equally. Maybe they need oxygen, maybe they don't, but look at all the choices and see what's really specifically matches here in terms of what you know you would actually do, because you guys do know how to treat a lot of stuff at this point, and you should have an idea based on a given situation what you think would be the best for a specific patient. 108. You have two patients that were involved in a motor vehicle crash when their SUV struck a tree. One with neck and back pain, and the other with a deformed left femur. The patient with the deformed femur states that he does not want to be placed on a hard board, nor does he want a collar around his neck. What is the most appropriate and practical method of securing these patients and placing them into the ambulance? As you read through these answer choices, just be aware both of these, or all of these answer choices, are written with this idea that you're going to have 2 patients in one ambulance. So because we have 2 patients in the same ambulance, we have these 2 options, the wheeled stretcher, which is what you're used to putting patients on, and you also have the squad bench, which is, remember from your ambulance ride-outs or from the tours, the long, flat, padded bench along one side. You got the captain's chair, you've got the other little seat on the side, and then you've got that long bench, which is usually used to carry the monitor, the machine that kind of keeps track of everything, or occasionally you'll be sitting on it if you're administering to a patient, but it is also useful for transporting. It can be used. So, you have a patient that has neck and back pain. What do you need to do for him? Yeah, you need to do a standard immobilization for that patient. C-collar, immobilized to a long backboard, put him on something. I know some of these choices offer squad bench versus wheeled stretcher for him, but put him on something, clearly. For the other patient with the deformed femur, what would your best treatment method be? Traction splint, yes, probably so. We don't really know where that break is. It says deformed, and that's kind of a general term. What specific type of break is a traction splint indicated for? Specifically for a mid-shaft femur fracture. So if it's like right above the knee or way up here at like the ball and socket, like hip joint area, it's not indicated for those. It's just somewhere in between on the actual like straight shaft part of the bone that you'd want to do that. So we don't really know. It's maybe a reasonable assumption to say traction splint's probably a good idea. That would be my first thought too. So traction splint, splinting it somehow, certainly. And then what else for him? He doesn't want a hardboard and he does not want the collar. Can he make this consent decision for himself?
Well, if he wants treatment, then no, it doesn't necessarily maybe.
You have to make this decision. Remember, when can somebody make their own legal consent decision? Obviously, they have to be an adult, not a minor. What are the other types of things we have to take into consideration? Yeah, so they have to be conscious. If they're unconscious, we have to do that whole implied consent, like treat them the best way we know how. They have to be capable of making the decision, right? We're looking at their mental status, trying to make sure that they are mentally capable of understanding what's going on. Whether you've got a patient who's intoxicated or has lower enough mental capacity that they just can't understand, which you won't run across too often, certainly not without some sort of guardian along to kind of help. But you want to make sure your patient is capable of making this consent decision. And you have to decide when you're doing this question, because some of these answer choices involve you doing what he tells you he doesn't want done, right? So you have to decide, can this patient make that consent decision? Can he refuse to wear a collar and have a hard board or have a backboard somehow strapped to him? Let me put it this way. Is there anything in this question to make you think that he's incapable of making that decision? Because does he have any sort of head injury that we're aware of? Does it mention a mental status problem? Okay, we cannot assume that there is a problem like that. That would be overthinking this question. To say, oh, well, he can't make that decision because that's not the best treatment for him. Even if something is the best treatment but against a patient's wishes, if they have the mental ability to make a consent decision, you have to follow what they say. Even if what they say is, no, don't do anything to me, I want you to leave me right here. Don't even touch me. If they're mentally capable of making that decision, you have to do it. You can't say, well, I think it's better for you if you come in and I'm just going to take you in anyway. Like we talked about the reasons why somebody can't consent. I guess another thing I would have to say is if they're in police custody and the police are already like transporting them, they can't say, no, police, you can't arrest me. But they could still tell you, no, you're not allowed to treat me. I don't want to be in the ambulance. As long as they're able to making that choice, you have to stick with what they say. So this patient made that choice. Therefore, what do we know about choice A? Is it incorrect or correct?
It's incorrect.
Definitely incorrect, because he says he doesn't want a collar or a backboard, and choice A has you putting both patients with a collar and a backboard, and we know that's not okay because he didn't consent to that. I think all of the other choices don't include that. Okay, so the ones that I heard most people saying were B and D, right? Let's look at B. Immobilize the patient with neck and back pain on a long backboard and place him on the wheeled stretcher. Any problem with that? Okay. Place the patient with the deformed femur on a folding stretcher secured to the squad bench. Any problem with that? Okay. That could be a reasonable choice. If you didn't necessarily know what a folding stretcher is, you might have some questions about whether or not it's the best choice, because it's not a piece of equipment you'd really hardly ever use. But you can look at it and say, well, I don't see anything super obviously wrong, right? Look at D. Apply a traction splint to the patient with the deformed femur and place him on the wheeled stretcher. Anything wrong with that one?
Yeah, I just think you should be putting in a wheeled stretcher when you're saying with the spinal injury.
Okay, that's a consideration. If you have your patient with a spinal injury in the backboard and everything, you want to make sure that they're the one that you can put in a more accessible place, right? And like as in a place where you can get to them, and also a place that you can easily maneuver them because they've got that big long backboard. So that's a consideration. Other than that, as far as the actual treatment of your patient, any problems? It basically just the traction splint is all you did, or all it mentions. We talked about how a traction splint might be okay for this patient. We're not entirely sure, but we can't necessarily rule that out. So the second patient, place the patient with neck and back pain on the squad bench. We kind of already talked about why that might not be best. Immobilize with a cervical collar and scoop stretcher. Are there any problems with that particular part of the treatment?
Is the scoop stretcher really like
What is a scoop stretcher indicated for? Hip and pelvic fractures, right? We don't know of any hip or pelvic fracture with that patient, therefore that would not be correct. This is one of those things where it's like, it's telling you to do something that you just don't do. It's not even that it would be wrong. It's not that a scoop stretcher would actually hurt that patient. It's just not correct. It's not your standard of care. It's not how you treat that type of thing. It's a real clear indicator. Nope, not this one. Definitely not this one. And also, it's true, you really would probably not want to put the femur patient on the stretcher and the other patient on the bench. If that were the only problem I had with this, then it would be a real minor thing, because relatively that is minor. But there's actual treatment concern here as well. And we didn't really talk about C. We'll talk about it real quick. Immobilize the patient with neck and back pain on a long backboard and place him on the squad bench. Allow the patient with the deformed femur to sit on the wheeled stretcher.
they're just not even taking care of the femur?
Yeah, so you have the neck and back pain on a backboard and on the squad bench, which we already said squad bench, not the best. But literally you're doing nothing for the patient with the deformed femur. Do you let them just sit on a stretcher ever? No, you need to secure your patients. That's part of your standard of care. When you're writing it up on patient reports, if you're ever working as an EMT, you'll almost always be required to write that you secured them. The way I used to do it was straps times 3, rails times 2. In other words, we strapped them 3 times across on the stretcher, and we put both rails up on the sides, like where the arm, kind of like armrests with the rails. Because that is what is showing that you secured your patient. It was in the report. It had to be there because it was the standard of care. So you're just allowing them to sit on the wheeled stretcher. It doesn't imply that you're actually doing anything to help. It's just not correct. B is correct because there's nothing wrong with it. It fits your standard of care. It fits what you would do for those injuries. There's nothing inappropriate. So this is one of those where you really need to take each individual section of each answer and dissect it, because it's so easy to skip over a relatively minor detail that overall helps it not add up. 109. A 59-year-old male with a history of emphysema complains of an acute worsening of his dyspnea and pleuritic chest pain following a forceful cough. Your assessment reveals that he has a barrel-shaped chest, unilaterally diminished breath sounds, and tachycardia. What is the most likely cause of this patient's condition? There's a whole lot of information in this question. You have patient history, you have signs and symptoms, you've got a lot of stuff. Looking at it, let's see. He has a history of emphysema. He complains of an acute worsening of his dyspnea. What is that saying without all the medical jargon? So dyspnea is difficulty breathing. Acute worsening means, did it happen over a long period of time, or is it all of a sudden? It was a sudden thing. So something happened, and all of a sudden it was hurting a lot worse. And he had a lot more difficulty breathing. Do we know anything about what might have caused that? Look at that sentence. Look harder at that sentence. Emphysema is his history, but what do we know about the sample questions that is tucked away in this sentence? Okay, so what would forceful cough, what part of sample does that fit under? What about events leading up to the injury, right? It's real small, it's tucked away in there, but it is in there. So you know he has a history of emphysema, and you also know specifically this pain worsened after a really forceful cough. Alongside that, you also have assessed your patient. He has a barrel-shaped chest. What does that fit in with that we already know? It's a classic sign of emphysema, somebody with a barrel-shaped chest. It points to a long difficulty of breathing. You'll just basically see them. Their chest is more, instead of a normal chest, which might look kind of oval-y, like say from the top, it's more rounded because of the way that they have learned, like their body has just adjusted to trying to deal with this persistent difficulty breathing. Unilaterally diminished breath sounds. So if you're listening to the breath sounds in their chest, diminished, tells you something. And tachycardia, which probably comes from what? The difficulty breathing and the pain both are going to cause tachycardia. That's just a basic kind of side condition of that. You're in pain, your heart starts to beat faster. Okay, so looking at these causes, is it likely that his diaphragm ruptured? Do we know anything about diaphragm rupturing? No. If I really didn't know the answer to this question, I would still probably take that one off, because that just seems so far outside of the kind of thing we've talked about. We haven't talked about your diaphragm literally rupturing. And realistically here, it wouldn't. There's nothing to point to it. Mostly that would happen in a trauma scenario. Some sort of impact from outside the body could cause that muscle to tear, but it wouldn't be just this forceful cough and the pain. Also, the pain is specifically, it says pleuritic chest pain, so it's talking about the lungs, and really the area around the lungs is hurting. It wouldn't be the diaphragm, which would be a very specific and different kind of pain. So A's out. What about B? Exacerbation of his COPD. Does he have COPD? Yes. Good. I'm glad you got that. Because emphysema is considered part of the class of COPD, what's the other condition that we usually name when we're talking about COPD? Chronic something. Starts with a B. Chronic bronchitis. So if we say COPD, we're usually meaning one of emphysema or chronic bronchitis is what they have. Would exacerbation of his COPD fit what we've seen in this question? Possibly. Okay. He already has it. It's an existing condition, so that's a reasonable assumption that it might have just continued to become worse. Acute pulmonary embolism. And then D is spontaneous pneumothorax. And I know you're all just looking at it like, I don't know, because there's 3 options on here that you might think are reasonably good, because you don't necessarily know how they would present or what would be causing them or something like that, correct? Okay, that's okay. This is one of those questions that you might see on the test, but it requires a very specific knowledge of emphysema. In this case, the answer is D, spontaneous pneumothorax. So you kind of have to know that emphysema can cause spontaneous pneumothorax. It is a side condition or a secondary condition to emphysema. If you don't know that, it's going to be a little bit harder to do this question, understandably. Another thing that might point to spontaneous pneumothorax, either C or D instead of B, would be we're talking about an acute worsening following a forceful cough. Okay, so both of those words or both of those phrases are referring to some sort of specific event, like something happened. And what that means is that we're probably not going to call it exacerbation of COPD, because what does exacerbation mean?
Is that like progressively got?
Yeah, exacerbation just basically in general means it got worse, but it doesn't point to any sort of cause. So knowing that there's some sort of event, like something actually happened, acute worsening after a cough, it's like a specific thing, it's unlikely that his COPD, his emphysema just got suddenly worse after he coughed. Doesn't quite fit what we're seeing presenting in this patient. Both acute pulmonary embolism and spontaneous pneumothorax do happen suddenly. Spontaneous pneumothorax especially could happen after a forceful cough. That word forceful, okay, so he has trouble breathing anyway. He pushes out a really hard cough. His lung collapsed. That was the spontaneous pneumothorax. Like I said, you'd kind of want to have a little bit of the extra knowledge about emphysema to decode this question. But if you could at least get it down to those two based on the wording, that would be a good start. And you will sometimes have questions like this where you're just like, I don't know. Has to do with a very specific condition. I don't know. And you just got to do your best guess. Get it down to two answer choices and guess between them. 50% chance is better than 25. So, any other questions about this? This particular one is kind of difficult. Okay. Number 110. You are caring for a critically injured 27-year-old female. During transport to the hospital, what should you do? The answer is A. Take her vital signs every 5 minutes. That's basic knowledge. We know that we have to take vital signs every 5 minutes for a critical patient, and how often for a non-critical patient, a stable patient? 10 to 15, yeah. You definitely would not do B or C. B is not bad to complete the form, to fill out your stuff as you go along. However, it's certainly not a priority when you have a critical patient. If you have a stable patient, yeah, you might as well try to get some of their history as you're going along and take the, if you can watch them and assess them and also ask them questions and get some of that stuff done, that's great. But this is probably one of those situations where you're really not caring too much about a full medical history and things like that. You have a critical injured patient. Good.